Good afternoon, everyone. My name is Lois McCloskey. I direct the Center of Excellence in MCH Practice Science and Education at BU School of Public Health. And on behalf of our center and our sister Center of Excellence at the Harvard T.S. Chan School of Public Health, I welcome all of you to our webinar today, which is part 2, Midwifery, an evidence-based solution for disrespect, racism, and other challenges in maternity care. We held part 1, as many of you know, to a very large audience just about a month ago, and the reception was so great. There was so much curiosity and great questions, we decided to invite our panelists back for part 2. So thank you, panelists, for agreeing. Our purpose today is to bring the conversation full circle to address the big overarching question: what are the next steps we, as a large MCH, public health, midwifery, and clinical community can take to advance midwifery in this country, especially in the face of racism and so many other system-level challenges within our healthcare? So I'd first like to introduce our 3 original panelists as well as an additional guest, and then let you know how the next 55 minutes or 56 minutes are going to go. So first we have Dr. Holly Powell-Kennedy, Varney Professor of Midwifery at Yale School of Nursing. And many of you will know of Dr. Kennedy. She's a longtime practitioner, a scholar of the midwifery model, and an international leader in this regard. We next have Ebony Marcus, Director of Midwifery at the Community of Hope, Washington, D.C., a trailblazer practitioner, fierce advocate, leader for the role of midwifery in advancing racial equity and altogether in advancing quality in maternal health care. Dr. Jean DeClercq, Professor of Community Health Sciences at BU School of Public Health, and of course, a well-known, internationally renowned scholar and advocate for midwifery across the world. Our extra invited guest, thank you so much for joining us, is Allison Northrup, Associate Director, Public Policy and Government Affairs at the Association of MCH Programs in Washington. So we invited Allison because she is such a hands-on expert in particularly legislative policy, which is gaining so much momentum in the United States at this moment. So here's how it's going to go. Each of our panelists will give some introductory remarks. First, Dr. Kennedy talking about the framework for quality of care in midwifery and neonatal care, which will set the big picture, followed by Ebony Marcus, who will then take us on the ground to talk about the role of midwives, focus on practice and implementation. Then Jean DeClercq and Allison both will, in different ways, give a few remarks about where we are with policy to advance midwifery right now. Each of them will talk very briefly, 3-4 minutes, that's it, because most of this is going to be devoted to your questions and discussion, which is, I think, a great way to do part 2 of this webinar. First, Jean will moderate a conversation based on questions that have already been raised in part 1, and then open the conversation for the last 20 minutes, 15 to 20 minutes, to take your comments and your questions as well today at the end. So will you give us a quick look, Anissa? She's guiding our slides today. Thank you. At the word cloud that shows the themes that came up in part 1 that Jean will moderate a discussion with other panelists about. So we look forward to that, and then carrying it forward with your own comments. So please use the chat when we finish these first 2 sections, or any time really, to place your comments, and use the Q&A tab on Zoom to ask your questions. We hope that will be clear and everyone can do that. I think it'll keep us well organized for this second part of this webinar. Thank you again, and I turn it now over to Holly Kennedy as our first panelist to give a few remarks. Thanks, Holly, and everyone.
Thank you, Lois. Next slide. I think that we were just amazed at the breadth and depth of the questions that were put forward in the chat at our first presentation. And we decided that it would be helpful to bring us back first to the framework that we had talked about, and then we sort of organized those comments into different themes. And what we thought we would do is look at those in terms of the quality maternal and newborn care framework that I brought forth last time from the Lancet series on midwifery. So as you might recall, we started the talk last time with looking at how we approach care and whether, next slide, whether we are doing that from a risk or capacity focus. Next slide. And this is the framework that I'm talking about, and it's an evidence-based framework that examines 5 different components of what we do. Next slide. So the first one is practice, in the green going to the pink. And in that blue box that just came up, I pulled several of the questions to sort of support this part of the framework. So in this one is, how can strengthening midwifery care work within or to change the approach to who serves which birthing person to reduce inequities? So what is it that we do that makes the difference? The next one is how care is organized. And that is about, is care accessible? Is it available? Is it acceptable to people who are looking for maternal and newborn care? Is it of good quality? And one of the comments from the chat last time was, I thought, very pertinent to this, in that voices of marginalized and minority groups are rarely at the table, and that we need more birthing centers in local communities so that people in their community are best being served. Next slide. The values on which care rests is about respect, community knowledge, and understanding the context of the childbearing person. And one of the comments was, I'd love to see an effort towards more inclusive language and messaging. Very important. Another comment, there were several comments about the concept of weathering and institutional racism. And when you are constantly battered by racism, how that potentially has the outcome of changing the health of people. And there are various ways of looking at that, but one comment that one person said that they had a colleague who talked about melanin as a risk factor. And when you take something to such a discrete variable like that, that in itself can be a problem and completely takes away the need for respect for the individual person. Philosophy, so what, for example, the framework talks about optimizing biological, psychological, social, physical capacity of each person that's giving birth and pregnancy and then becoming a parent, and expectant management. And this one, this comment was about looking at trauma-informed care in improving reproductive justice. And then finally, the very last one, next slide, is about who provides care and how providers are not only prepared, are they prepared to be competent in interpersonal communication, but are they deployed appropriately? For example, if there are not enough midwives, especially of color, there's certainly physician barriers and not enough funding for education. Next slide. So just a reminder, all of this, except that little pink box up there, is the scope of midwifery practice and what midwives do and the foundation upon which it rests. Next slide. But this little pink box, which is the referral services for medical, obstetric, and neonatal care, is where the majority of funding, both research and educational funding, goes. So how can we reverse that balance so that the the majority of support and funding is going towards preventing having to use those referral services. So that's just a brief recap of what we talked about last time. I'll turn it over to Ebony Marcus now.
Good morning, everyone. I as well, looked at our lovely chat from last time and just wanted to highlight a couple of things and give a little perspective as well about being a midwife and what it means to be a midwife taking care of under-resourced individuals and working more so in community health. We need more innovation in these models, and we need to make sure that these models are also accessible. And when I'm talking about access, there was a lot of comments about out-of-hospital birth, but there's different layers to that, like talking about licensure for all pathways in midwifery being addressed, because it is a problem depending on which state that you're in. It's about the training programs, the education programs to increase the workforce, to be able to provide more options, birth centers that accept Medicaid, but even flipping it to say, like, making sure that insurances pay for whatever type of birth that you want to have, whether it be hospital, home, or birth center. Another thing that I saw really stand out in a lot of the comments was about cultural congruency and like why. And I can just speak really specifically on what I focus on exclusively with Black maternal health. It feels better to see somebody that looks like you taking care of you, and that's just the reality. And just to even break it down in a simple way is, a lot of folks have to feel like they have to code to it, or prepare themselves a certain way to try to possibly improve the care that they're seeking. And when you see somebody that looks like you can take down the stress a lot by feeling like you may not have to over explain or present a certain way. So culture and community is very important, and it's not about knocking our providers who are not BIPOC. It's more so addressing the fact that institutionalized systematic has affected the amount of BIPOC individuals in all the professions. So, constantly I'm always arguing that there needs to be more midwives of color, but we need everything. We need more lactation, doula, MFM, OBs, radiologists, everybody. Like, there just needs to be more representation from in all professions. And on that same thread, I definitely want to make sure when we're talking about being inclusive, yes, there isn't enough conversation about our Latina midwives and also our Native midwives. We have some strong work being done on the West Coast from these two communities that are not highlighted and addressed in the ways that they should be. And these are also populations that are suffering the same disparities, who also would benefit from cultural congruency, who are just not spoken about and represented as much. And then also talking about the fact that, yes, very common threaded in a lot of presentations, the use of women and not saying birthing persons, because absolutely not every person that that gives birth is a woman, identifies as woman. And the last thing I just wanted to add, just to kind of close it out, is Dr. Joya Career-Perry was the lead in this comment that it's not about race, it's racism. Racism is leading to why we're having the outcomes that we are having. And just a shout out and some love to, especially I feel like Black women who are feeling this from our systems. We are not deficient. We are not less. There's nothing wrong. We are not broken. We have to talk about the systems that are affecting us. Thank you.
Okay, I guess I'm next. If we can go to the next slide, I'm going to talk about two things. I'm Gene DeClerc. I'm going to talk about two things that came up in particular. One was workforce and the other was a little bit on policy. If we can go to the next slide, one of the questions was about balance. Is there an ideal balance between the number of obstetricians and midwives? And this is from the last presentation. I'll just note it again. This is comparing the US to other industrialized countries. And you can see a slightly smaller number of obstetricians per births. But when you compare it to midwives, that's where the imbalance is. And if anything, what you see is a balance in those countries, virtually all of which have much better outcomes in the United States, of about twice as many, 2.5 times as many midwives as there are to obstetricians. In the United States, we have about 1/3 as many midwives as we have obstetricians. And so I don't know what an actual balance is. And I asked my colleagues that, and they weren't sure either, but it ain't what we have. And clearly there needs to be some work to try to address that. Another question that came up was, yeah, you can go ahead to the next slide. Another question that came up was talking about types of midwives. And in the United States, the two dominant groups are certified nurse midwives, of which both Ebony and Holly are great examples, and certified professional midwives who are licensed in most of the states. There was a question about a midwives illegal in states. And it's less a case of illegal as it is to being unrecognized in those states, not legally recognized. The point I want to make with this slide is, A, there was some newer data and I wanted to show it. It just came out. But oftentimes there's not enough support between certified professional and certified nurse midwives. And I think this slide really illustrates the fact that states that have a large number of certified nurse midwives also tend to have a larger proportion of certified professional midwives. And so the issue is not CPMs or CNMs, it's CPMs and CNMs. They serve somewhat different populations depending on the state, but their interests are greatly allied and need to be fostered. And the policy efforts that we're talking about going forth shouldn't be a matter of dividing up the little power midwives have, but all midwives joining together to advocate for policies. Speaking of policies, if we can go to the next slide, there are a bunch coming out. And these are some of the bills that have come out of late. The Black Maternal Health Omnibus Act of 2021 has a whole section on perinatal workforce. There was a bill literally called Midwives for Maximizing Optimal Maternity Services. There's a bill that just came out last month to address maternity care shortages and promote optimal maternity outcomes by expanding educational opportunities for midwives. These all sound really cool. The problem is not all of them will pass. In fact, most of them won't pass. And the question then becomes for advocates, what do you support? What do you push for? I could talk about it, but then I wouldn't really know what I was talking about. So let's turn to Alison Northrup, who actually does. And she can speak to more specifically how these bills may proceed and which things we should really be focusing on. Alison?
Thanks so much, Gene. So I'm going to take us a step back for just a moment. So all the mom bills, this is a tremendous time, tremendous moment for congressional attention and national attention, frankly, to improving maternal health in the United States and eliminating racial inequities in maternal health outcomes. And you can see that in the sheer number of bills that have been introduced. We're only a few months into this Congress, and already there are 31 bills by my count that have been introduced related to improving maternal health. The bolded bills are those that explicitly reference midwives or midwifery, and even some of the non-bolded bills refer to healthcare providers where the term is not defined, but presumably would also include midwives. Next slide, please. And the topics covered by all the mom bills, these are some of the buckets that these bills address, and midwives and the patients they serve would be impacted, frankly, in each of these areas, but two areas of particular focus or interest related to midwifery care are those bills that address improving maternity care, including things like implicit bias training, respectful maternity care, and of course, growing and diversifying the perinatal workforce, which in several areas specifically focuses on midwives and midwifery. Next slide, please. So in terms of how to conceptualize what of these 31 bills to focus on, what might move, some good framing questions that I ask myself to start with are, which bills are bipartisan? Because that can be a good proxy for what has gone through some pre-negotiation to get to some kind of consensus and ultimately pass through both houses of Congress. Another good indicator is which bills have advanced beyond introduction, which bills have had a hearing in the Committee of Jurisdiction or been marked up by the Committee of Jurisdiction. You want to look at potential vehicles to passage. Some bills pass just as standalone bills, but oftentimes we see bills pass in big clusters or packages, what are sometimes called omnibus bills. And I'll discuss that in a moment. There's also an opportunity for action through the executive branch. We have in the White House, of course, President Biden, but Vice President Kamala Harris is a phenomenal champion of maternal health and Black maternal health in particular. And she led the Black maternal health momnibus when she was in the Senate. So that can be another area for where we could see some championship related to midwifery care. Next slide, please. In terms of potential legislative vehicles this year, you have more options for bipartisan bills. Things can go by unanimous consent or committee packages. A number of the bills in the Black maternal health momnibus at this point only have Democratic support. That includes the Perinatal Workforce Act. These bills, though they have less avenues for passage, there's actually still a route for them this year because the Dems control both the House and Senate, and they have slim majorities, but some legislation could move as part of what's called a reconciliation bill sometime this fall. Next slide, please. Okay, and just one more quick note. So some of the bills that Jean mentioned, the Midwives for Moms Act is one that's specifically focused on growing and diversifying the midwifery workforce, and specifically on growing and diversifying the racial and ethnic and linguistic diversity of the midwifery workforce. And that bill is bipartisan. It meets one of those, threshold questions of what might be likely to move. And so that bodes well for that bill. Likewise, the Babies Act, that's focused on reimbursing freestanding birthing centers under Medicaid. That too is bipartisan. So that bodes well for that bill. We will likely see a package of maternal health bills marked up, considered by the various committees of jurisdiction sometime after August. And I am very optimistic that we will see legislation move this year. And the offices that sponsored all of the bills related to maternal health are always looking for organizational support. So that is one way that you can help to advance these bills and help them hopefully get across the finish line this year. Thanks so much.
Let me just amend one other point to Allison's presentation. Thank you. That was terrific. That's what we needed. Sometimes, and hang around, Allison, because you may want to comment on this. Sometimes these may be less than they seem. And if you're going to advocate for bills, one of the things you might advocate for is to really drill down and figure out what's in the bills. Anisha, if you can skip to the last slide for a second. I broke out the Midwives for Moms bill. And if we're going to advocate for it, what we have to advocate for is more funding for it, because when you break it down, and this may be one of the reasons it could pass, right, is because the funding in federal terms is pretty limited. It's 15 million for 5 years, which would be 3 million a year, 50% of which has to go to direct support of students, which would be about $1.5 million total for the entire country for support for students, and about $750K for expanding a midwifery program and $750 for increasing the number of preceptors. Those are all great goals. They're just underfunded. And so part of the game that happens is symbolic rewards are given to us because we're not politically powerful. And in federal terms, $15 million is actually symbolic. They don't actually mean much. So I think part of this is understanding which things to push for, and then understanding of those things, how do we leverage it so that it actually has an impact? Because as Holly, as a former program director, can speak to, $750K to establish programs means program, and it isn't going to have as much impact. Unless I screwed that all up, Allison.
You did not screw it up, and my guess is that this is one of the bipartisan bills among the maternal health bills introduced this Congress, and that often means compromising on the funding level referenced in introduced legislation. That doesn't mean that's the final number. This is an introduced bill. Bills change throughout the process of committee hearings, floor amendments, so that there are additional points where you can push for what is actually needed to carry out a meaningful program. So we still have those opportunities ahead of us.
And in fact, the fact that it has some momentum behind it means that we have something to push for. Then it's not arguing to have them actually deal with the bill, it's to say how much, which is a whole different kind of conversation. Okay, let's turn to some of the questions that came up in the last session. And I'll turn it to the whole panel to respond to this, so you guys can come back. That first question, what's preventing more midwifery care in the United States? And a lot of questions around how can we diversify the midwifery workforce? And that was one of the questions that just came up on today's chat, Q&A as well. How do we actually achieve this? How do we get a larger and more diversified midwifery workforce in the United States? If you could just solve that for us, I'll give you a whole 5 minutes to work that through.
I'll be happy to start and then turn it over to Ebony. Because I think Ebony and I both work at midwifery education in different ways. I'm with a traditional nurse midwifery program, but one of the hardest things that we have is getting preceptors, people to take our students. And Ebony is one of those wonderful midwives out there in service who takes on students for us. But the nature of work today, it is so hard to manage a student in the clinical setting. And so having ways to reimburse, and those, when I look at those funding levels, they're just paltry in terms of what's really needed. And if you compared that to resident GME funding, it would be, I would love to see a graph on that. So the other thing is, in diversifying the midwifery workforce, is we really should, from a very large helicopter view, think about how do we create educational opportunities and ways to learn about midwifery in the community setting, so that people, one, learn what a midwife is, two, start to become employed in various aspects such as doula care, whatever, but with the idea of going on that trajectory and hopefully making midwifery education, one, much more local and much more affordable.
Other points I'd like to highlight is, we need to talk about the education programs that exist. I work in education, like Holly was saying as well, and just the amount of trauma that a lot of BIPOC students express going through their training and through their education, and that there's no real platform to really address that. That's a huge issue and a part of this as well. I don't think anybody's ever looked at it, the amount of BIPOC individuals that maybe even started and then quit just because they couldn't handle it. Or they were so traumatized from the experience. So we still have a lot of work to do with educational infrastructure, especially regarding racism, that also need to be addressed to help increase diversity.
Again, we could talk about all these questions for a long time. I am going to move to another question that came up, and it's the last one on this list. At one level, we need to diversify the midwifery workforce. At another level, there's still institutions that midwives will be working within as well. And I think this is a really pertinent question. How can patient-centered nature of midwifery be incorporated into large teaching hospitals that tend to be resident learning centers.
And one of the people in the Q&A session also brought this up, in that not birth centers may not be for every single childbearing person. And but what we try to do in teaching, both we're in a large teaching institution with residents, is that one, collaboration is really important, and doing a person-centered model of care with continuity, if at all possible. So a birth center is in some respects a state of mind about how you approach providing care in any setting that you're in, and what are the things that you can do to support physiologic birth. So if you're working in a large teaching institution, the team needs to be constructed of all providers of residents, medical students, midwifery students, midwives, obviously, obstetricians. And so when you're planning that care collaboratively, of always asking the question first, what is supporting this person's physiology? And if we're going to intervene, what's the evidence for that intervention, and is that needed? So Ebony?
Yeah, I just wanted to add, because I saw that too, is that I'm really not arguing that birth has to be the answer, center birth is the answer for the issue. I'm more so arguing about having the option, that it's an option that's denied. And then, yes, and especially me, who definitely decided my pathway to be more impactful in the hospital, in a lot of the systems that I feel like are definitely causing harm. There needs to be a growing greater appreciation for what midwifery can do in hospital spaces, as far as, like Holly was discussing, supporting low intervention birth, but also co-managing higher acuity to maintain, continuity. There's a huge role for midwifery in the hospital. So again, I'm really also want us to focus. I'm arguing for option. I want to, and I'm eligible, can I get it?
Ebony, that's a great point. When I was studying in London, doing a normal physiologic birth, the consulting obstetricians would say to us, if they didn't care how complicated or at risk the person giving birth or the pregnant person was, they all needed a midwife in order to support all the psychological, social, and physiological aspects. And the consulting obstetrician took care of, the more complicated things, but they were a team. So it's not either or, it's a team.
There's a famous line in England: all women, all birthing people need a midwife, and some need an obstetrician too. Right. And that's one of the ways to conceive it. That's not possible in the United States, just given the workforce numbers we're talking about. I'm just going to note one other option in considering this question about how do we deal with large, not necessarily just teaching hospitals, but large hospitals. And that is another British model, which is the midwife unit within a hospital, in which there's a center in which midwives are within the hospital. So it's not a freestanding birth center, but they basically run that, and it's for lower risk patients. The importance of that is, if it can be run in a way that allows the culture of midwifery to really be infused in that setting, it ripples out throughout the rest of the hospital, because people start to see what birth can really be like. And so that's not an option that's available in many places, but it's something we might consider in the United States as another step. I don't see one solution to these things. I see a whole array of solutions, from home births to high-tech centers. We need all of those things, but we need them for different populations, and structuring a system that respects that is where we can go. Can we go to the next slide? This is just a couple of these questions I think we've talked about. One is just a sort of, again, somewhat of a political question, and Allison and I were both referring to national policies, but a lot of the action happens at states. And I won't mention the state this person referred to, but they talked about the fact that in their state, midwifery is severely oppressed. What can we do to bring information to those places to try to address systems that restrict midwifery practice. And I would make the argument that it's a little bit about data and a lot about politics and understanding how politics works and the kind of information that you convey. So I tell my students all the time that if they really want to influence policymakers, they need data and they need stories. And they need to be able to translate data into understandable contexts that people in the policy world will understand and relate to. And so there's no magic bullet here. It takes a while, but the growth in home birth in the United States and the growth in the number of certified professional midwives, which has been profound in the last 15 years, has come about partly because of demand and partly because of the activism of the people involved who understood how systems work and made those kinds of changes. Last question, and then we're going to open it up to the current conversation. Did the pandemic change any of this? There's been a lot of talk. One of the points that this questioner raises is they heard there was a lot more interest in home birth. I study this data all the time. There isn't data yet. There's a lot of anecdotal evidence about an increase in home births, but there's nothing concrete that's out there yet. But that did open up discussions around home birth and midwifery care. Do you sense, the two of you sense any changes as a result of the pandemic in shifting the way people think about the birthing process in the United States?
I'm going to be probably not the popular opinion, maybe not positive, but yeah, I mean, I think wanting out of hospital birth out of fear is not the way to go. I want people to want out of hospital birth for different reasons. We see a lot of folks who are in our area, you know, definitely feeling like that's what they want to do, but really not prepared mentally, psychologically, or even sometimes for the folks that wanted and eligible from a physiologic standpoint for what birth center birth really means. So for me, I'm sad because I feel like people want it primarily because they're scared, not because they are wanting midwifery, wanting low intervention birth, wanting what all that means.
I would agree, Ebony, and we've done some, we've been doing some studies, qualitative studies about this, and it is about fear, but I do think it might be a moment to capitalize on that, to begin to help people understand that maybe the hospital isn't the best place for a low risk person to give birth, and sort of build on that. Really to help people think about what choices are you making and why.
Let's open it up to the folks here now with questions that they may have. And we've got a few that have already been posted. And one of them addresses the issue of retention. That how do we make sure we don't lose? And we've been talking about how we add to the midwifery workforce. But this raises the question of the other side of it, burnout and workforce retention among midwives. You guys can solve that for us now too. What is driving midwives out? I guess that's the way to think about it, right? What is causing midwives to leave the profession?
I mean, we could have a whole nother session on just that, but some of the things that just pop right automatically into my head, just thinking about that, the amount of, maybe hours and work you have to do to maintain a practice, especially from an entrepreneurial standpoint, what it is to build a practice, licensure. God, I can keep going. There's a lot of different things that are pushing us away, and it really is related to the overall system and infrastructure. So, like, for example, if we had insurances appropriately compensating, not like half-ass compensating, but legitimately compensating for, midwifery services, then it wouldn't be such as hard of a task to pay for all the infrastructure you need to have that practice. There's a ton of reasons why.
Yeah, I would agree. I think that so all those things that Ebony mentioned, and then the dissonance between wanting to practice a midwifery model of care, which midwife students learn as a student, and then from almost the day they step into the clinical setting, there's a dissonance of being able to actually do that. And you know, the frustration about not being able to give the kind of care that you really know is needed. So one of the things that I think is very helpful, and that I have been in some practices that do this, is to schedule a sabbatical for people, to build that into your work model of your practice, where people can get a few months away, you know, that where they can work on something. I mean, it's difficult financially, but if you can build that in, I mean, certainly in academia, we do that to renew ourselves and work on things. So that's one thing that I've seen practices do, and just to have enough people to support the practice.
There was a, go ahead.
Can I add one more thing really quickly? Yes.
Oh, okay.
Dr. Canty, definitely want to add in there hostile work environment, whether it be talking about the hierarchy in medicine with our physician colleagues, and then also the racism that's experienced in these settings. So the hostile work environment also contribute to why folks are leaving.
There was a question specifically about a program like Yale, which is a prestigious program, and the challenges that you all face and how you address them in trying to diversify your student body. How do you do that?
We don't do it well enough. We have been working at it, but I will tell you that I don't think we do it well enough. We have been instituting different programs for more support of students academically, to really try to reach out to them. And it's not just students of color, but certainly all students. The best recruitment for a program for any reason are the students. And so having students reach out and say, yes, Yale's a good place to come, or Columbia's a good place to come. And I think one of the best ways to look at this is to look at, and the directors of midwifery education in the United States, at least for nurse midwifery and that are certified by AMC, work on these issues. And one of the most important things is to really look at what schools have the most diverse student body. And if you look at those schools, they are more likely to have a more diverse faculty. Mm-hmm. So students often will say to us, the faculty don't look like me and don't reflect. So that has been an area that we have focused on, and but we still have a lot of work to go on that.
If there's anything if there's anything I definitely want to bring home today, is that all of these pieces are still not really, are really small in comparison to the overall structure. So we're talking about faculty, right? We're talking about wanting more BIPOC faculty. Why do more BIPOC individuals not go into academia? There's a lot of different things that can be addressed there. Hostility also, but also thinking about funding, school. If I come out of school with, over 100K of debt, it's harder for me to take an academic job where I make less money. You see what I'm saying? So like a lot of these smaller issues really, really start up here. It's a lot, it's all about our systems.
Yeah.
Yeah, at one point I tried to build up a proposal to expand midwifery education. Holly knows this. And I was trying to work through the numbers involved, and the numbers are huge, right? Because of all of those different components. You have to diversify faculty, that costs money. You have to provide more scholarships, that costs money. You have to provide for preceptors, that costs money. So I didn't mean to pick on that one bill, except for the fact that their funding was so lame that they're not going to have much of an impact unless they literally increase the amounts more than tenfold to have any reasonable impact on these kinds of things. And that may seem like a lot of money, but A, not in the context of federal budget, B, not in the context of what we would gladly spend for a new technological device that was being developed. And so the impact of diversifying the midwifery workforce isn't going to be the 5 years of utility that you get out of a new technology. It's going to be a generation of somebody serving the population that really needs that support. There's another question here, asking a question about hospitalists and laborists coming in. And I recall when I first read an article about laborists, maybe 15 years ago, and they were describing it, I said, okay, that's like the British midwifery model, where midwives are working in the hospital. And then I got to the end and they said, of course, this is only OBs. The question they're raising is this a threat to midwifery, the use of hospitalists or laborists now?
I think it depends on how you approach it. So if you look at the UK, there are caseload midwifery practices where midwives have continuity of care throughout, and we know that that's a very good model. But they also, most of their institutions have midwives who do the interpartum care and midwives who do antenatal care. There's pretty good communication between the two and philosophy of care. So I think there are various ways of approaching it, but it really comes back to your approach of how you support the childbearing person from all those aspects of the framework. If it's, it is concerning, I think, about also, so in the UK model, there's a midwife for every woman who's doing all the care for that person during the labor and birth. Whereas the hospitalist model that I think Linda is referring to is someone who's sort of out managing the whole floor and sort of, and that's not one-on-one care. That's not going to support the person's physiology. That's it's a totally different model. So there are concerns with that.
I'm going to also add in there, yes, it's an issue if it's a them, not us. So if you are hiring laborists because you feel like you don't want to hire midwives, then it absolutely is a problem. Mm-hmm. But if you're hiring laborists because it's what's needed for your model, for volume, or whatever the case may be, that is still inclusive and supportive of low intervention and midwifery model of care, it's not an issue.
Yeah, it's all about how you put it together.
So there was another question about the sort of unique history of Black midwifery in the United States, and how do we maintain and expand on that legacy? Is there anything different from what we've already said to address that? I don't want to ignore that question, but I know we've talked a lot about the expansion and diversification of the midwifery workforce. Anything we can build from our history, which is not the most noble history in the world, obviously.
So I do want to expand on that. So I commonly will talk about how I feel like when I am practicing midwifery, I'm channeling granny midwives, my ancestors, and there's a lot of really beautiful and indigenous practices that come from that time, from that community, that are not utilized. But even to break it down even further, why it also needs to be talked about, like thinking about in experiences in midwifery training and interactions culturally. There are ways that we communicate with our community that are not textbook in midwifery, and that students and faculty have been penalized for doing what we just know is right. I can't tell you how many times I've had on the eval that I'm unprofessional, and yet here I am. But I think it's important to acknowledge the fact that from that history, from that time, granny midwives were not just practitioners; they were community leaders. They were respected. Their boundaries were very different than what we at medicine try to enforce. And so a great example, just because everybody's like, why? But like, I remember having a colleague who I adored dearly frustrated with a student that she was training because she referenced the patient as mama. And she thought that was extremely offensive. In my community, that's how we identify elders. We put a mama in front of their name. So now this instructor is essentially causing harm and penalizing the student for something that's culturally what she knows.
Ebony, if I can just add on to that, I think what I'm hearing from you and in the works that I have read by granny midwives is they know the community. They know the people in their community. And when you know the people in your community, then you are so much more at the root of being able to provide the best care that's tailored to their needs. And that's all in the framework that we've talked about. We're doing a study in Uganda of a birth center that's had 14,000 births and has never lost a mother. And their neonatal outcomes are better than for Black women in the United States. And what our assessment of why is they know the families and the people in the community, and there's traditional midwives and nurse midwives working together. And it's not about machines, it's not about technology, it's about knowing the person.
There's an interesting question about the role of consumers, but Lois has been monitoring the chat. I don't know if there's anything you want to bring in here from other comments that have been coming up.
Yeah, well, there's a lot of great comments about what you're all talking about now, very much reinforcing it. But I wanted to go back to a comment that was raised earlier, make sure we don't miss it. So this was a comment about, the question is, how can we organize CNMs to advocate in solidarity with CPM? So it's a question more about the hierarchy within midwifery. And she also raises the importance of, if we want to diversify the midwifery workforce, we've got to go a lot further with these grants in the legislation and establish CPM pipeline programs at community colleges. So they'd like you, person would love you to speak to that.
I can speak to it very quickly. I think if you look at the work that's been done by Dr. Saraswati Beedham, is the integrated in a state, and that includes CPMs, CMs, CNMs, the better your outcomes. That always needs to be at the top of the list. There was one comment in the last chat of the last presentation that we need to think about restructuring how education is done, and whether that is looking at different, i.e. community college. I think we have to have some more very creative and innovative thinking about this if we're gonna increase the workforce. Ebony?
Simple things like CPM should be able to train at CNMs who are doing out of hospital birth. CNMs should be able to train with CPMs who are. I don't think that we in our community appreciate the pathways the way we should. I know I personally, professionally have tried to create spaces for us to at least fellowship more in our region. And for me, I hope it's also giving other, sides of the fence opportunity to grow and know each other more. Another great example I like to tell my students, depending on what state you are, I'd easily be working with the CPM. And I feel like we don't always know that from the CNM side.
Right.
Yeah, I mean, that's why I put up that slide earlier, actually, quite explicitly to indicate the shared interests that CNMs, CPMs, and certified midwives, the other group that doesn't get much mention, all have in these cases. Let's maybe finish with this last question about what can pregnant persons do to help midwifery? And I'm just going to open with, honestly, I think CPMs have been better at organizing politically than CNMs have for quite a while. And in Massachusetts, there's been an effort led by a consumer, Emily Anesta. I'll shout out for her. She's done a magnificent job of sort of organizing and working with the state legislature to try and get through licensure for CPMs. And that was consumer driven. It wasn't the midwives doing it, it was the consumers doing it. I don't know, you guys can speak to this. CNMs, do they reach out to their consumers? Do they have that same kind of support that I know CPMs tend to have? Partly because home births are a more personal kind of event, but.
It depends on your state. I'll give you an example from over 30 years ago in Rhode Island, when we were going after prescriptive privileges. The main thing that probably shifted the legislature was that the Secretary of State was attended by a midwife and got up and testified. And so those stories, as you mentioned, Jean, are so powerful in whatever aspect of moving the ways that people think, and needs to be extremely creative. So.
We have about 3 minutes
Talk
left.
about the
Final
money.
comments?
Jean, there's one. Oh, go ahead,
Yeah.
Ebony. Sorry.
Really quickly, money. We're going to talk about the money. That profession, those organizations,
exactly.
there's a difference in money. More money they can pay for somebody do their legislation work for them, like money.
Yeah, and speaking of money, there's a chat comment here. Equitable and adequate reimbursement for maternity care has to be part of solving this. That's kind of the big picture question. And birth center midwifery models just aren't sustainable without it. Any comments on where we are on that? Or how to get there?
Yes, I mean, I feel like there's been more talk about birth centers. I also just don't, I worry that the birth center is being glamorized and it is being prioritized as like the top solution. You know, speaking back to Henry's comment about how birth center isn't for everyone. But I think that it's becoming more aware that it's there, it's an option. But I still think there's a ton of work to do, making sure that birth centers are compensated appropriately. You know, that way they can sustain.
I would agree completely.
And I would throw in my pitch that I make to strangers I meet on the street about thinking about breaking down some of these barriers that we have and having federally qualified health centers start thinking more about working with birthing centers because of the linkage to the populations that really could use birthing centers and the resources. There's cultural issues and challenges there that are not insignificant, but again, there's not one solution to this thing. One thing isn't going to change it all. It's a systems problem that came about from 100 small things, and we're going to solve it through 100 small steps, but they have to be taken and they have to move forward. And hopefully what comes out of this is a greater commitment to trying to move those things forward.
Great. Good note to end on. Jean, Holly, Ebony, thank you. Thank you to Allison, for everyone who's been listening and chiming in with great questions once again. I want to make sure that you know this has been recorded. We will post it on our Center of Excellence websites and just as important, mail it to you because we have your names and emails when it's ready. And I think what we'll do is post and send both part 1 and part 2. They are a set. And I want to encourage us all to stay tuned this fall, as Allison told us earlier, when mom's bills are going to be pushing through and get center stage again. So keep our eye on that and our own advocacy. Thank you.
Lois, I just put
Yes.
a website in the chat for people to, it's one way to continue this conversation, especially around midwifery research.
And you mean our center website, Holly, or a different one?
No, this is a different one. It's qmnc.org. It's Quality Maternal and Newborn Care.
Okay.
Okay.
Anissa, could you do that, please? Thank you, before we sign off.
And if Allison could post maybe where people could track these things, that would be helpful.
Yeah.
Yeah, so funny that you say that. I am close to finalizing a tracker, actually, of all the bills that have been introduced so far this Congress. So keep an eye out for a bill tracker of all the maternal health bills from AMCHIP, and I can also follow up and see if we might be able to send that out once it goes live, and it'll list, brief summaries and kind of the status, bipartisan status, and give you a sense for what bills might be moving.
So there we are, thank you very much, Anissa. And we'll wait just 1 second if you're able to post that tracker, Allison, or do we need to do that later?
Later when it publishes.
Got it. Okay, sorry about that.
No worries.
Thank you.
Thank you.
Thank you. Wishing everyone an excellent day. And here's to midwifery. Thank you, panelists. You're
everyone.
beautiful.
Thanks, everybody.
Bye-bye.